Right. Hello, everyone. Thank you for joining us again or for the first time, depending on how long you've been with us. I am Akia Lewis. I'm the Strategic Innovation and Get Georgia Reading Project Manager at Georgia Family Connection Partnership. I'm sorry, I don't know why I'm stumbling over that today. We want to thank you so much for being with us today. We know you could be doing any number of things on a Friday afternoon, and we're happy you're Zooming with us. And while we're doing thank yous, we have to give a big shout out to the Sandra Dunnigan Deal Center for Early Language and Literacy at Georgia College, our host today. The Deal Center is a great partner and friend of the campaign, a cabinet level partner, and a big advocate for early language and literacy around the state. Teresa, the executive director, is here with us today, and she wants to give you a few words of welcome. Teresa?
And on behalf of the Deal Center team, and again, in partnership with the Get Georgia Reading Campaign, we welcome you to the virtual learning series with early language and literacy experts. Some of you joined us yesterday, so welcome back. I know that we had a great day yesterday, and again, you're in for yet another great day today. I am Teresa Magpuri-Lavelle, and I am supported by a wonderful team at the Deal Center. I have the opportunity to lead this wonderful team as the executive director. And as Akia said, we're housed on the campus of Georgia College, which is right in the middle of the state, because we have a very clear statewide mission to improve literacy rates for children and the families of Georgia. We work every day. You will see today as one of the presentations, as you saw yesterday, we serve as a vehicle for the state of Georgia to disseminate the very important information that is needed to support children and their families in early language and literacy development. And as you will see today in today's presentation, all of the factors, the multiple factors that affect learning and therefore will affect the learning of language and literacy. Our quest is to embed evidence-based practices in organizations working with children birth to age 8 by focusing on three main areas: research and quality improvement, professional learning, and community engagement. As I said before, the presentation today will be similar to yesterday's, where it's rooted in science for the goal of transformational change and sustainability. I also want to let you know that all of the videos, the presentations are being videotaped and will be accessible on our website in a couple of weeks. Please check out the website in general. We have multiple resources, and you can find out more information about who we are, what we're doing, and our goal for the state of Georgia and beyond. Without any further delay, I'm going to send it back to Akia and just enjoy your time today. Thanks, Akia.
Thank you, Teresa, and I am very excited to have the opportunity to present our speaker for today, Mary Lauren Salvatore, who is the Health and Wellness Coordinator at the Georgia Department of Education. In this role, she's really been an advocate for raising the issues of health and well-being to the forefront, especially for children who are in our chronically lowest performing schools. And she's going to talk to us today about how she does that work. Take it away, Mary Lauren.
Thank you, Akia, for the introduction, and thanks again to the Deal Center for the opportunity to present today. I'm really excited to talk to everyone about health barriers to learning and what that impact might look like in your community. So just to give some credit, I've had help putting this presentation together and on a lot of my work from Ariane Weldon, also of the Get Georgia Reading Campaign and Georgia Family Connection Partnership. And hopefully Ariane will be able to help me tag team on maybe answering some questions after the presentation today. So we'll go ahead and jump right in. Just want to make sure everybody remembers to put questions in the chat box. We'll save them to the end, but make sure to go ahead and put them in there as they come up as we go along. So our objectives for today are to define what non-academic health barriers to learning are. We're going to provide evidence for the impact of health barriers to learning on students and educate you, the audience, on tools, resources, and actions that can help address HBLs in your schools and communities. I just want to pose a couple of questions. I imagine that some of this information might be really new, so just as a couple of things to think about as we go along, some things to start thinking about and maybe creating questions and thoughts in your own heads. starting out with trying to consider existing policies, procedures, practices, and programs that positively impact children in your school or community. Think about why those programs are beneficial and what makes them a success. Does your school or district have a protocol for screening children for basic health needs such as vision and hearing? Or perhaps some type of a form that's required at the beginning of the school year that requires children to have these screenings done? And lastly, what do you see as barriers to making student health a priority in schools? And then to start thinking about how we might overcome those barriers. So jumping in to define what health barriers to learning are. They're considered prevalent and persistent health conditions that, when left unrecognized or unaddressed, can interfere with a child's ability and motivation to learn. Just to set the stage, a little bit of background about why these HBLs are important. This concept of HBLs provides shared language, understanding, and a sense of urgency around health factors that are affecting children in the classroom, and not just in their academic outcomes, but in their life and health outcomes as well. And as we go through this presentation, you will note that a lot of the things that I talk about have to do with having a public health lens or a population-wide lens. And really, it's looking at HBLs in a way that it challenges individuals and organizations and schools to forge partnerships with organizations and agencies that might already be focused on this work, or maybe just one of the HBLs, but thinking about how you can create some unique partnerships to partner on things between school and community, and to inform the development of what we were considering systematic approaches. So again, that population-based approach, looking at innovative and creative responses to problems and factors that are persistently affecting student outcomes, not just in Georgia, but across our country. To think about what might influence a health barrier to learning for a student, we'll show this figure, and it is not an exhaustive list of factors that influence these health barriers to learning, but certainly some important ones here are poverty, housing, healthcare access, insurance status, stress, family, and health literacy. And I want to take a pause here to highlight on health literacy, because I know this is a literacy audience, and I imagine a lot of you spend a lot of your time, really focused with efforts on improving children and family literacy. So hopefully talking about health literacy will be able to help you to really connect your work to this work of addressing health barriers to learning. So health literacy is the degree to which an individual has the capacity to obtain, communicate, process, and understand basic health information and services to make appropriate health decisions. So when I'm thinking about health literacy, I started to think about the concept that I learned not too long ago about learning to read and then reading to learn, and thinking about a context of that in the classroom for a child as they move around third grade and they have now flipped that switch of reading to learn. So in terms of health literacy, it kind of works the same way. You have to be able to read and to understand health information that's being provided for you in order to learn and make decisions about your own health. So I think it's just an important concept to remember as we move through today, to think about that connection between the work in child and family literacy and health barriers. So to put an emphasis on this health literacy piece a little bit more, think about patients that might have low health literacy, so people that have a difficult time making a decision or processing that health information. These types of patients are more likely to visit an emergency room, more likely to stay in a hospital, less likely to follow a treatment plan, so something like taking medication or routine practices that need to be done to maintain maybe a special diet or to keep up with a special chronic illness, and then ultimately can lead to these patients having higher rates of mortality. So this is a great graphic by CDC just to display really what the impact of health literacy is. And to start here, we'll talk a little bit about beginning to tie in this concept of social determinants of health, which are the determinants that, the factors that influence health due to where we live, work, go to school, play, and grow. So really how your community has an effect on your health outcomes. And here, this is a map that's been pulled from the Get Georgia Reading campaign, data tools, and the purple overlay that you see in the back is shading based on child poverty rate. So the darker the purple is closer to children living at or above 35% of the federal poverty level. So you'll see that there's a lot of dark purple happening here in the bottom part of our state. There's also a lot of dark purple in this area of South Metro Atlanta. And then you'll see these dots overlaid on the state. And the dots represent elementary schools. And the color of that dot is based on that school's third grade ELA proficiency. So it's pretty obvious here to look and see that the dark purple shaded counties in our state often have red dots on top of them. And those red dots are showing that those elementary schools are hovering around 20% or below of third grade ELA proficiency. So just to give kind of this overall look at how poverty in communities might be correlated with reading levels and academic outcomes. And now we're going to jump into the actual health barriers themselves. And I want to give some credit to the Children's Health Fund, who released a really great study. And there's a brief executive summary that is definitely worth reading that just outlines what these health barriers to learning are and what this evidence is that shows the impact that they have on students. So we're going to go through each one of them, starting with asthma. So nationally, children with asthma miss almost 14 million days of school a year. It's one of the leading contributors to chronic absenteeism. And consequences of asthma that's poorly controlled are frequent emergency department visits and hospitalizations, and miss school due to, some of these things, and also to just poor control and, the consequences of being asthmatic and not having it be regularly treated. And in our state, around 160,000 or 9% of children have asthma. In Georgia in 2017, just to give a little bit of context around healthcare spending, around $55 million was spent due to emergency department visits, and that accounted for about 25,000 visits for children aged 0 to 17 in that year. This map is, you'll see a little bit similar to the map with the purple background. This map shows asthma prevalence among children in Georgia by health district. So again, this darker shading represents rates of asthma between 12 and 16%, and it's heavily concentrated here in the south and south central parts of Georgia. Now let's take this a step further to look at asthma and third grade ELA proficiency. So it's the same thing here, looking at asthma as the background of the purple. So the darker the purple, the higher the rate of ER visits for asthma per the population. And then again, you'll see these overlays of dots for elementary schools. So you can also look here and see these dark shaded counties, and a lot of them frequently have red dots on top showing low ELA proficiency in those specific counties. The next is oral health, or dental pain is what's identified as the actual health barrier. So students who are experiencing oral health concerns are more likely to report feeling unhappy, worthless, withdrawn, and or overly sensitive. It can lead to trouble sleeping and eating, increased school absences, difficulty paying attention, and lower academic outcomes. And hopefully we can all relate to this one here about what it feels like to have a toothache and just trying to focus on anything else but how much that hurts. And then trying to take that context into a student in a classroom who maybe has had a toothache for a week now and hasn't been able to have anything done about it or communicate that they're having that issue. And recently in Georgia, there was a study done on third grade students to show that 50% of those students had a history of tooth decay, and about 20% of that went untreated. And based on national statistics on childhood oral health, those numbers are very consistent. The next is vision problems. So if we think about what it looks like to learn, about 80% of our learning occurs through visual tasks like reading and writing. So I think it's safe to say that for children who don't have the tools to see correctly, or that haven't had a vision problem be diagnosed, they're already at a deficit for learning in the classroom, or in the current context, behind a computer. So common vision impairments affect up to 25% of students, and if they go uncorrected, they can lead to physical, developmental, behavioral, and academic problems. And as with all of these other health barriers that we're talking about today, they disproportionately affect underserved children in low-income and economically disadvantaged communities. Next is hearing problems. So think about hearing problems and language. Even a minimal hearing loss places children at over 4 times the risk of language skill deficits compared to their peers. Children who have trouble hearing are at a higher risk for social, emotional, and behavior problems. And from a statistic point of view, nationally, about 10 out of every 1,000 children will have permanent hearing loss by school age. And I imagine some of you, as you're in the early childhood space, might be familiar with newborn screening protocols, that nearly every child who's born, I think the numbers are around 90 to 95%, are screened for hearing at birth. But in the newborn screening world, there's a lot of issue with loss to follow-up. So while a child who is successfully screened, diagnosed, and received the services and maybe devices that they need to hear correctly can have a very normal trajectory where they've got the tools that they need to sit in a normal classroom and learn. But there's also then those students who didn't get that follow-up care, and they're struggling persistently with inability to hear in some capacity. It's important to note also that not all hearing problems are genetic. There are other contributors to hearing problems, such as trauma to the ear, persistent exposure to loud noise, and chronic ear infections can also lead to some degree of hearing loss. The next is food insecurity, and this is one that is really near and dear to my heart and has been a part of a lot of the work that I've done in my current role over the last year and a half. So we'll define food insecurity as when families have limited or uncertain access to enough food. Food insecurity can often be mischaracterized in behavior as defiance, depression, and anxiety. In our state, pre-COVID-19, this data is from 2017 from Feeding America, that children in Georgia, 1 in 5 are likely to suffer from food insecurity, and that's 350,000 students in the K-12 space. And I think it's really important to note that this is pre-COVID-19, and 20% might seem really low, especially due to, in the past several months with school closures. And I know in Georgia and across the country that school nutrition departments have stepped up immensely to serve kids and to serve families with meals, and federal nutrition assistance programs, bulking up some of their services in order to combat these needs. But I do think it will be really interesting to see in a couple months or maybe a year from now what the food insecurity rates look like and how they differ from before the pandemic. And just to give another snapshot here into Georgia, if you all aren't familiar with the Feeding America Map the Meal Gap tool, I would highly recommend just visiting that website. It's a really easy to use, easy to navigate map that drills down to county level data on food insecurity. It talks about eligibility in federal school meal assistance, cost deficits that would be needed to get to actually achieving food security. But I just think this is a really interesting map to look at of our state. So the green here obviously is the shading for food insecurity. And I think it's safe to say that this dark green space in some shade covers about 75% of our state. So that means that even though that state average was 20%, all of this dark green shading shows that several of our counties are between 20 and 30% food insecurity. And if that isn't shocking enough, these orange dots overlaying this map are locations of regional food banks that are associated with the Feeding America Network. And for instance, I know this orange dot here is the Atlanta Community Food Bank, but the Atlanta Community Food Bank doesn't just serve this area right here. The Atlanta Community Food Bank serves all kinds of counties up here. This is the Feeding the Valley Food Bank located in Columbus, Georgia. And you'll see it's located about an hour and a half north of a concentration of the highest child food insecurity rate counties in our entire state. And just recently, that food bank was able to open a second location that is actually in one of those communities to better serve that population. So again, I just think this is interesting, and it's important to think about it and acknowledge the context and the relation between children who suffer from persistent hunger and their ability to achieve and succeed in the classroom. And I'm going to pause here before we get to the last two health barriers, just to give a little snapshot of Southwest Georgia. In my current role, I was able to conduct with many coalitions in these communities of volunteers health screenings, and all in all was able to screen over 600 students across 5 different districts and 6 different schools for each of the health barriers to learning. So you'll see here, and this is just a snapshot of the physical barriers. So we're looking at asthma with a prevalence of 45%, food insecurity at 36%, uncorrected hearing problems at 9%, oral health high risk at 60%, and uncorrected vision problems at 23%. And to jump back in, these last two health barriers that we have kind of given a different context in the work in Georgia and added language skills in, because there's so much excellent work being done around language and literacy in our state that we knew that this was something that was really important to look at. So developmentally appropriate language skills have demonstrated a protective effect on students' mental health, and students who aren't meeting their developmentally appropriate skills might struggle with the use of inner dialogue or the essential ability to effectively reason, regulate their own emotions, and cope with problems. And lack of these language skills can frequently be misinterpreted and mischaracterized as other behaviors like inattention, opposition, and conduct problems. I want to take a second here on this slide to tie back to this health literacy piece and think about that decision-making aspect. So if a child is struggling and not up to par on their language skills for age, and they're having a hard time reasoning or regulating their emotions, how might that affect the way that they make decisions about their own health or communicate decisions about their own health? Or simply back to that child in the classroom with a toothache. What if they didn't know how to communicate what was hurting in their mouth? It could be, you know, not just that they had one tooth hurting, but their whole mouth had been hurting for a week, and lacking that ability to communicate and then to effectively regulate that pain and emotion. I think it's just really important and echoes through each of the different health barriers to think about how those things are so strongly related. And lastly, I think this one is really, really important and kind of ties all together each of these health barriers, and that's student engagement and well-being. And in the Children's Health Fund literature, this last health barrier is technically defined as certain mental health and behavior problems, but we again wanted to expand the context of that to really look at engagement and well-being. And I think this aligns really well with the SEEKS framework through the Deal Center that I'm sure many of you are familiar with. But looking at a student's ability to communicate and engage with others, and thinking about what other factors might be playing a role. That ability to communicate and engage is significantly associated with a child's emotional and mental health. It can have, you know, different types of outcomes on social, emotional, and mental health development. And then thinking about that lack of engagement or student well-being that is just not where it should be, Now that you have all this great context around these different health barriers, I think it's really safe to say that there are lots of things that could play a role in why a student isn't engaged in class, but how getting them to that really improved high level of well-being could really have a positive effect on their outcomes. And I kind of want to wrap up this section just by talking for a second about social emotional learning. And I know that's been something that's been extremely in the spotlight in the education space over the past several months due to the pandemic, and I'm sure will continue really for the foreseeable future and beyond. So I think when we talk about that, and I think that relates, really well to student engagement and well-being, but thinking about, again, that population health approach and that approach of encouraging social emotional learning and mental health awareness on a school and on a population level can really have a demonstrated effect on positive engagement and well-being for students. So I think just as we move forward, one of those things to keep in mind is really just thinking about not just the students that you're really targeting that might be affected by these things, but really being able to take that population-wide lens. Okay, so now we've talked all about the evidence behind these health barriers, and I'm going to take the next section to walk through some tools and resources for what to do about them. So overall, some important items to consider, and we've definitely thought a lot about how the context of our COVID-19 pandemic plays into this, and looking at whether students are going back to school or not in the fall. But we wanted to give some suggestions about key things that schools should be prepared to do, whether children are coming back physically into the building or if they're going to be learning online. And one of the things we think most important here is for schools to be able to collect student health insurance and physician contact information and registration paperwork to determine if students have a doctor. And that's really important because we want to make sure that ultimately students have access to primary preventive care. And we know that that's not a reality in every nook and cranny of our state and many states, but just being able to give schools that awareness and understanding of where their student population is could help them be prepared to provide different types of resources and supports inside the school building. The second is to find ways to provide families with information about food access. I know we talked a lot about that, but as somebody who's in a school and supporting the school community, it's really, really important that those relationships with school nutrition departments are strong right now, and that things are being really well communicated from the top down and all across school communities about what food access is going to look like in terms of school meals and other types of community support for food. And lastly are these documents called wellness checks that we've put together, and I'm going to give a snapshot of this on the next slide. So you'll see this is the quick wellness check for elementary. We developed a very similar one for secondary students, and then another really similar one for staff, as we think staff wellness is going to be also extremely important as the return to school happens. So they're all laid out very similarly, and you'll see on the top it's asking which zone are you in today. So you'll see kind of a emoji-like smiley face or not so smiley face at the top, with the opportunity for children to check off what they're feeling that day. This could be self-administered, this could be administered by a teacher and students are doing self-report, or even for online access to put something like this into a Google form or a Microsoft form to have online abilities to access and to analyze. And the bottom section is really tied directly to the health barriers. So you'll see there's a question about breathing and asthma, a question about food, one about hearing and vision, and then the last one about dental pain. So how you would want to use this would be to identify where most of your students are falling, both in the top portion of this form and the bottom. So if you notice that at the classroom level, and then maybe the conversation turns to the grade and to the school level, that a lot of children are saying, we haven't had much food at home and I'm afraid I'll only get to eat at school. or you've got a lot of children checking off that they're having a little bit of a hard time seeing, that might be a trigger that you at the school would need to look into some type of support program or solution to address this problem if it's really affecting a bigger part of your school population. And to take that example right into asthma, so if a child answers yes to the asthma question, that they are maybe in fear that they are going to have an asthma attack or that their asthma has been out of control, the school would first want to verify that that child had an asthma action plan on file. And an asthma action plan, just really briefly, is a document that outlines protocols for a student with asthma on a good day and on a sick day and a crisis, so that the school would be prepared to react in any type of a situation. And given if the child did or did not have that asthma action plan on file, then that child would need to be referred appropriately. So depending on what resources the school had, whether that be a school-based health center, to the school nurse, or if they do have that ability to link out to a primary care physician. These are the types of protocols that we would want schools to have in place, or at least have the understanding of what they could do to help serve these students. And then what I've done on the next several slides is broken down each health barrier from a larger toolkit that we've created, and that toolkit link will be shared with everybody at the end of the presentation today. But essentially the toolkit looks like this. It lists the health barrier. It has a column for screening and observational tools, a column for follow-up actions, and then in the actual toolkit there's another column that has suggested partners. And you'll see, I think here on this slide particularly, for example, the Ronald McDonald House Charities, CareMobile, Metro Atlanta only. Some of our resources are definitely Georgia specific, the way that they're listed, but it's likely that a lot of these are replicable in other states and other counties like departments of public health. And a lot of these are online resources as well. So the screening and observational tools that you'll see on the left, like this 12-item asthma questionnaire, are resources that have been vetted by professionals. They were used in our Southwest Georgia cohort of schools screening. And one of the really, really important things to notice about this toolkit and about the tools that we're suggesting is that almost all of them are free of charge, or if there are multiple options for the tools, at least one of them is free. We did not want this at all to be a toolkit that was going to be cost inhibitive for anybody. And in the columns where there are tools that there are multiple options and some of them are associated with cost, in the larger toolkit we've provided detailed information about how you might mitigate or share those costs. So I've talked a lot about asthma, but just to highlight these follow-up actions, I would highly recommend looking into the indoor air quality tools for schools action kit and asthma-friendly schools toolkits. Those both are filled with really great information about how to create asthma-friendly environments in school buildings and outside school buildings as well. For vision problems and hearing problems, these slides are really similar. We're providing a couple of options for tools, instructions on how to complete a screen, who needs to do it. But really the impetus here for vision and hearing is just to have a screening protocol in place. We reference in the toolkit the American Academy of Pediatrics Bright Futures Periodicity Schedule, which mentions at each level of from birth through adolescence when certain things should be screened for. So that's a really, really great reference tool to use when a school might be designing a screening protocol to understand when exactly is appropriate to screen for these things. And really the same thing for hearing here. I'm going to go ahead and skip on to the next one. Oral health, I can't recommend enough that your local Department of Public Health, either district or county health department, is going to be your best resource. There's a really strong chance that they have services that can be provided to schools free of charge. We also, in our Georgia context, we're able to tap into a partnership with the local technical college system who had schools of dental hygiene. and we're able to send local dental hygiene students to perform services in one of our schools. And it was a really, really great resource and experience for both those students and for the school to see that they did have this resource not too far away from them, and for those dental hygiene students to be able to get this supervised practice experience in a real life community setting, something that they weren't used to before. For food insecurity, I'll highlight too, this 2-item food insecurity questionnaire is a tool from the Food Research and Action Center that's meant to be used in a pediatric clinical setting, but it's a very easy to use and administer tool that might be a great thing for schools to consider as we come back, just to understand again what that new rate of food insecurity might look like in their community that it hadn't before. Really to highlight again that importance of linking eligible families to free and reduced meals, offering weekend backpack programs if that's some type of an option in your community, establishing a relationship with your local food bank, and just overall being consistent and communicating well about what can be offered and what types of unique partnerships can be created to make sure that students and families are getting fed. And these are also a little bit nods to the Deal Center. The engagement ladder and language skills by age band are great tools that are meant to be used on a classroom level. They're observational, and they're meant to inform Tier 1 instructional practices. So you'll see that there are links to each of these for both language and for student engagement. The only difference here on this student engagement slide is that we have this emotional well-being check provided, and the emotional well-being check is simply the top portion of that overall wellness check document that I showed a few slides ago. So it's kind of just those 4 smiley faces or emoji looking faces to determine where students are at on an emotional level or zone. And these can all be linked out through the toolkit as well. And I'm not going to jump to the toolkit itself because everybody will have access to that, but I believe that's my last slide. So I'm going to go ahead and pause here and stop doing the talking and see if anybody has any questions.
Thank you, Mary Lauren. We just got a question actually. Cheryl Cooper Smith asks, is there a mandate that all schools have a nurse on site at least part-time as a support to these health barriers?
I don't believe there's a mandate in place for that. I know at least in Georgia, we have lots of schools that don't have school nurses in any capacity. And in a lot of our rural districts, nurses for sure are shared, sometimes not just among a cluster of school, but among an actual school district. So to my knowledge, there isn't a mandate for that.
Right, there's not a mandate. There's some recommended ratios, but there's not a mandate.
Yeah, it's a great question.
So another question, we've seen a lot of innovation during the pandemic, trying to meet the basic needs of children and families, especially as it relates to food. So it's kind of a 2-part question. Number one, are there any of those innovations that we all need to be aware of? And number 2, of those things that are happening, do you have hopes that some of them remain after the crisis is over?
So for the first question, I think one of the most important things, and the deadline was extended, and I believe it ended June 30th, but if you all aren't familiar, there's a program called Community Eligibility Provision that allows for all students in a school or in a school district to eat for free. And it was expected that as the pandemic increased and the unemployment rate increased, that many more families would be eligible for free and reduced meals than were before. So community eligibility provision is based on your school meeting. I believe it's at least a 40% threshold of families that qualify for free and reduced meals. So it was really, really important over the past month for schools to be able to collect that data. And there are systems in place on the county and state level that do what they call direct certification to see what families are automatically eligible for free and reduced meals. That data was collected, and then schools that were going to meet that threshold could apply for CEP. And CEP is an incredible program because it really just kind of eliminates that stigma around school meals, because nobody's paying a different amount. Everybody is eating for free. And I've seen a lot of push around CEP from organizations like Share Our Strength, the No Kid Hungry campaign, and the Food Research and Action Center as well, just really trying to push that CEP envelope. So I think that's kind of one of the key programs. And then to answer the second question, I hope that a lot of the urgency that has arisen over the pandemic stays after it ends. I think it's really helped to bring student health to the forefront, and for people to be really aware. Again, not just on that level of, I was thinking about, schools having what they're calling wellness checks, or what that might be, monitoring for students that are coming into a building every day, monitoring for COVID symptoms or doing a COVID test. And while that is super extremely important, just back to thinking about this concept of basic healthcare needs, and maybe that's being able to educate parents in some capacity about how to look out for these things and how to be aware, and for schools to have strengthened relationships with maybe a federally qualified health center in their community, or some type of a nonprofit health organization that can help to provide services where they're really needed. I know there's also been a lot of talk about telehealth. There are a lot of logistics and policy implications behind telehealth sometimes, but it's a really, really awesome resource. And I know that a lot of the restrictions actually, and Ariane, feel free to step in here if I'm speaking incorrectly, but they were lifted as a result of COVID-19 as a way to try to eliminate barriers to telehealth services. So I guess that was a long way of answering that question. But yes, I hope that they stay for as long as possible, because there has been a lot of really great innovation that's come out of it.
Yes.
And I added a link in the chat for pandemic EBT. So that is for families with children who are at free and reduced lunch, including, as Mary Lauren mentioned, the CEP district. So all of those would be eligible. There's a lot of detail at that link. And I want to underscore, just as Mary Lauren said, the ability for pediatricians to do well visits through telehealth. So if you're at home, you can just do it on your smartphone or on your computer. And that is something families can do right now. So that policy was changed, and we really encourage as many well-child visits as, families to take advantage of that as possible.
So we have another question about the toolkit from Jennifer Cardenas. She wants to know who can administer these assessment tools that are within the kit.
Jen, great question. In the toolkit, in the category where the tool itself is listed, there are suggestions for volunteers or people that are qualified to deliver them in that box as well.
Awesome, thank you. We have another question from Dawn Anderson. Because we have so many students without health insurance, or schools mandated to do the screening, how is that funded?
There are no mandates that exist for schools to do these screenings. There's recommendations, and I know in the context of Georgia, there's a form that's required at school entry and school registration that requires all of these items to be kind of checked off, that a student has been seen by a doctor and they've had these preventive screenings done. But that's the only requirement, is that it's done at school entry and at any type of registration point. So whenever a child enters a new district, but it's not required at any other point throughout a child's time in K-12. Districts have come up, I believe, in some capacities with their own, they might decide to screen for vision and hearing at certain grade levels, but there is no mandate around it. There's a really interesting study that was done about states in the US that had some type of mandate around screening for health barriers to learning. And of the 50 states, I believe there were only 12 states that had some type of a required form. And at that, I believe that DC was the only one that had exhaustively listed all of the health barriers to learning. So it's a huge gap.
And I'd like to add to that with Dawn's question about the health insurance. And you'll see this in the toolkit at the beginning, that one of the recommendations before even looking at the rest of the toolkit is just simply a linkage to health insurance. So you're right, there are, and even just simply finding out at the beginning of the school year, if you don't want to layer a bunch of other things, the name of the child's doctor, contact information, just to find out if kids have a doctor. Of any population that's insurable, children are the most insurable. So finding out that, and then also, as Mary Lauren was mentioning earlier, the connection with the medical home. So having linkages with the doctors in the community. So if there is a pediatrician or if there is a federally qualified health center, to your point, not necessarily layering too much all the time on the school, but even having families aware of going to the doctor on a regular basis. And so that again, it's not having the school become a clinic or take on something else, but rather that sort of let's connect together to support the whole child. So collaboration in that sense.
We have a question from Tammy Clark. Could our schools be an enrollment location for healthcare insurance?
I don't see why not. Just to that point too, I know one of the school districts that I worked with last year facilitated a health fair, which is a great thing to do. I know that might look a little different right now, but a lot of the MCO, the organizations, they have community outreach staff, so they will come out and they'll provide information on what you need to do to get enrolled, and that's something that they do as part of their job. So the resources are there to do that, absolutely.
Awesome. Can you share any aha moments with schools that have implemented this toolkit or any of the wellness checks?
So the toolkit kind of was created as a result of the pilot that was done with the screening results that I mentioned. So I was working with a cohort of 6 different school districts, and in some capacity, each of those school districts participated in a screening, whether that was 1 or 2 schools. And a couple of the schools, we were able to implement some follow-up interventions. So for example, we did a dental sealant program in one county. That was what I mentioned about the partnership there with the technical college and the Department of Public Health district. And we had a partnership for all the districts with a local organization called the Lions Lighthouse Foundation. And our partnership with them allowed for students who failed vision screenings to have eye exams performed on site at school, and then those children received glasses free of charge that were delivered directly to the school, required no transportation or mailing or really much additional paperwork from the parents' end as well. So they're examples, they're best practices, and that's kind of where we're at right now in the process of this, is trying to really get some schools to latch on, to be excited about this toolkit and see what we can learn from really implementing it.
What role do you see for community partners and nonprofit organizations in this work?
I think there's a really great opportunity for from partnership from the community, and that's a great question. In our case, there were a lot of people already doing the work. There are great connections with food banks in Georgia. Despite what that map looked like with the orange dots, they're trying to do the work. The effort is there and the intention is there. We have an Asthma Coalition of Georgia that does great education across the state to schools, to school health professionals, to teachers, to students. And then I think, when we were conducting these screenings, we utilized Family Connection partnership staff in different counties to help come in and do language screenings or mental health screenings, and we provided training prior to that on how to do it. So if somebody wasn't a social worker or an SLP, we gave them the tools that they were going to be able to deliver those screenings. So I think it's really just being able to connect individuals who want to help and that are excited and interested in this space to the school. And then giving them tools like this toolkit to say, okay, kind of here's the scope, where do you fit? I think there's always going to be opportunity for communities to be involved. And sometimes it's just giving them that, that tool to say, here's how I can help, here's what I can do. So this toolkit could be a great point of leverage for that.
Thank you. So for the students with language delays, does Georgia have the capacity to support their SLP needs? How is this being handled?
Ariane, I'll let you answer that question.
Great question. So, and hopefully if any of you were on yesterday and listened to the Language is the Missing Link presentation, sort of the traditional approach, if you really didn't know much about language and language skills, maybe to think, oh, we're going to screen and refer out of the classroom. The numerous opportunities to address language and supporting language-rich interaction in classrooms at a universal level really addresses majority of children. And so we're actually in the process and with support of the Sandra Deal Center and building a Language is the Missing Link toolkit. It's also as a result of a pilot, really a demonstration in Dublin City, Georgia. So again, an area that, high poverty, lower test score outcomes, but really innovated a practice to be able to understand language skill issues at the universal and education speak tier 1 level, and to be able to use that understanding as more of a canary in the cave, as opposed to use that understanding to refer children out of the classroom. So applying the SEEKS approach that you learned about yesterday, and that you'll see more when we post these. And then having your speech and language pathologists, and this actually also happened in Dublin City, join as partners. So they're really helping to support the teachers and the staff in understanding, supporting children in the classroom. Sometimes when we think about language delays, if there are issues that the speech and language pathologist is working on, it really may be more of a speech or articulation issue alone. That's really what some of the most prevalent issues are. And I hope that answered the question. So unless you want to add any more, Mary Lauren. I know you had some aha moments in communities that didn't realize the level of language skill issues going on that may have been mischaracterized as misbehavior, and provided an opportunity.
I will echo, not necessarily in the language category, but I think one of my favorite aha moments in doing this work in one of our particular rural districts in Southwest Georgia was a conversation with the principal as I was presenting results to him that just, wow, he couldn't believe that the results were what they were. And he said it really helped to give him a different perspective of things that he hadn't thought about before. And being in a really, really tough middle school with just chronically low test scores and poor performance. And this just kind of gave him another angle to think about things they could do to serve the students. So
have you had anyone wanting to see an immediate connection between a screening and, say, increased scores? I think one of the issues that we have had as a campaign is sort of, yes, third grade reading is important, but it's really a quality of life indicator. And I think this fits within that as well. Like, doing this is good for the student regardless. Have you had any sort of issues or pushback? How have people approach this? Are they looking for immediate results because there's now screening, or have people been pretty receptive to this as a good, for goodness sake?
I think generally people have been pretty receptive, and the results are going to be different, right? So the goal with these screenings, as with the work of the literacy work, is not just to find out what the problem is, it's to be able to provide those solutions, right? And while giving a child glasses or fitting them for contacts might in a day change the way that they learn, and they automatically do better in school because now they can see and read. But for things like placing dental sealants or creating an asthma-friendly environment in your school, that might take a couple of years to show results.
Right.
So I think test scores might not always be the best indicator, but maybe even looking at that level of student engagement and just overall well-being to understand like gradually where these things are going to make bigger impacts. But no, I didn't get any pushback on that front about making immediate or seeing immediate change.
Awesome. Are there any additional questions? There's still time for you to add them into the chat. If so, I will say that Emily has put a comment here. This is just a comment. It seems that data gathered and results of the wellness checks from an individual school might empower principals and school leaders with seeking community partnerships. Agreed.
Mm-hmm. Absolutely.
Thank you, Tammy. Well, so far I'm not seeing any additional questions. Do you, either of you have any final thoughts?
I don't think so. Just if anybody has, if you, after this is over, take a better look at the toolkit and have questions based off of that, or think of anything, or have experiences to share from how you've seen any piece of this work in your own community, I'd love to hear the feedback or answer the questions. So don't hesitate to get in contact with myself or Ariane.
Thank you.
Thank you so much.
Thank you so much. This was great information. Thank you, everybody, for showing up on a Friday afternoon, kind of at lunchtime. We appreciate it. Enjoy your weekend.
Thank you. Thanks, everybody.